Thank you, Professor Rosano, for your presentation, and thank you to the Translation Medical Academy for the invitation. I got the real hard task of making a resume or an abstract for a year of CCS news in these just 10 minutes, but I will do my best to show you what is new and what you should know about this. Okay, these are my conflicts of interest. And here's the agenda. I will touch briefly three points and three studies that you should know about chronic CCS and 2023. First one is the Multi-Society American Guideline for the Management of Chronic Coronary Disease. Most of you must be familiar with this guideline. It's very extensive, as you know, more than 100 pages, extensive and in long. So I just choose just 3 points, practical points from the therapeutic point of view for you to know, and you transmit this knowledge to your patients. The first one is a change in the recommendation of physical activity. We should continue recommending physical activity 30 minutes 5 times a week. That doesn't change anything. But now the Americans has changed something else. They have added that our patients with chronic coronary disease should include resistance or strengthening training among their exercise. This is because this kind of exercise has improved muscle strength, functional capacity, and obviously quality of life. And there's some evidence that this kind of exercise, strengthening muscle exercise, may also reduce mortality rates in individuals with chronic coronary disease. So remember, this is the first point, physical activity. Second point, beta blockers. This is a new recommendation for the Americans. Now they come with this new recommendation, long expected, because there were a lot of trials showing us that maybe beta blockers after the first year of myocardial infarction were not useful for preventing future events in this population. And now they come with a 2-year recommendation of reconsider standard beta blocker therapy, which may not be recommended for some patients who don't have left ventricular dysfunction, don't have atrial fibrillation, do not have angina, or any other compelling indication for this kind of medication. So remember, next time you see a patient with chronic coronary syndrome and beta blockers, ask yourself if that patient needs to keep on that kind of medications. And the third message from the American guidelines relates to disease-modifying drugs, SGLT2 inhibitors, and GLP-1 receptor antagonists. This time they come with a recommendation specifically for diabetic patients with chronic coronary disease should be treated with these 2 medications. SGLT2 inhibitors, you know, are very effective drugs for preventing heart failure events, and GLP-1 agonists are very good for decrease the risk of new coronary artery events or cerebrovascular events among those patients with cardiovascular disease. So we should now include this medication, ideally both medications, in the treatment of patients with chronic coronary syndrome, even though we know that in a limited resource settings like our countries, this may not be possible for all of our patients. Next is the main dish from my talk. Is a very important paper from the investigators from the Imperial College of London, and PCI as a first line for a treatment with a stable angina. They come with the Orbita 2 trial, a very important trial presented last year at the EHA meeting and published in the New England Journal of Medicine by the end of the last year. The objective of these investigators was to assess if PCI was effective in improving angina in patients with obviously stable angina and coronary artery stenosis causing ischemia compared to a placebo procedure. In order to do that, they included patients obviously with angina or equivalent symptoms. The patient need to have a test with evidence of ischemia and have a coronary artery anatomy suitable for PCI. That means that they had to have a coronary artery stenosis of more than 70% on a coronary angiogram or more than 90% on a CT scan of at least one vessel. After that, the patient were asked to stop their anti-anginal medication 2 weeks before procedure. And only those patients who had angina, at least one episode of angina during that period of time, 2 weeks, were taken to the cath lab. All patients were underwent coronary angiography and physiological measurements just to make sure that the coronary artery stenosis reported in the previous test was significant in physiological terms. And then they were assigned to PCI, opening the vessel with most modern coronary artery stents, or a placebo PCI, where the patient just remains sedated for 15 minutes. Then, after 2 weeks, they evaluated the results, and these results were measured by angina symptom score, specifically designed for this trial, and effectively, patients assigned to the intervention arm or the PCI arm had less angina score. That means that they have less episodes of angina every day. The daily angina frequency was less in those patients who had PCI compared to patients with placebo or placebo PCI. And also, these patients were able to walk a little bit more on a treadmill test. So what is that angina symptom score? And I would like to go a little bit further because we need to understand what this investigator did. That angina symptom score was a combining point of the number of angina episodes and the number of units of anti-anginal medications that the patient reported on an app designed by the investigators. So here comes the first problem to try to translate this result to my daily practice, okay? And then what they found was exactly the same as I told you before. Mean daily angina frequency was less in the patients and the PCI group versus the patients in the placebo group, but the use of anti-anginal medication was not different among them, which made me wonder what happened with these patients. If you have more angina, why are not using more medication for relieving pain? That is an uncertainty that I don't have, for which I don't have the answer. The investigator said that maybe this patient didn't want to take the medication, but I think it's a very simple answer to that question. A more familiar way to measure the effect of PCI was the time on the treadmill test. This is a modified Bruce test, and patients who underwent PCI were able to walk barely 59 seconds more in the treadmill. I don't know how important it is for our sedentary population. And if you tell a patient that he's able to walk more on the treadmill test, the patient may maybe tell us, well, doctor, I don't use a treadmill for my daily life, so I don't know how to translate this into the real practice. And this is the most striking finding for me. And more familiar, and maybe for all of us, is that the patients in the PCI arm obtain relief just in 40% of them. What that means is that 2 out of 3 patients remain with symptoms of angina after having the coronary artery open, which makes me wonder what is the external value of this test. So if in patients not taking angina medication, PCI improved some, but not all symptoms of angina, what does it mean for our daily practice? Well, I think that most patients with angina, inducible ischemia, and obstructive CVT will not benefit in terms of pain relief from PCI. That's important to know. And however, this PCI may represent an upfront option, a first option for some patients, especially those who are younger and who don't want to take anti-anginal medications. And finally, the same message that we were hearing for a lot of time: anti-anginal medications are more affordable and safer alternatives to invasive procedures like PCI. And that's in line with the most current recommendation from the Americans, which still maintain the paradigm of optimal medical therapy as first-line standard of care for patients with chronic stable angina, and leaving PCI for those who remain symptomatic. And finally, long-term prognosis with recurrent angina after surgical or percutaneous revascularization of patients with chronic coronary disease. We've barely seen long-term studies in cardiovascular medicine. Remember that we are used to see 2-3 years, and then the most recent studies are stopped. But now the investigators from the syntax test, I would like to remind you that this was a trial comparing the intervention of patient, the revascularization of patient with complex coronary artery disease, that means left main or three vessel disease, revascularized through PCI or surgical revascularization. Well, we heard the first results from this trial, from this long-term trial back in 2019, but now we hear what happened with those patients who remained or had angina after the first year of having been revascularized. Here's the flow chart of this trial, and you can see on your screen that 1 out of 4 patients remain symptomatic at the first year, despite the majority of them well revascularized, have a complete revascularization. And what happened? You can see here, overall, the patients who have angina at 1 year had more vascularizations at 5 years, which makes sense because most of the patients who had this kind of procedures were originally assigned to the PCI. So you expect that those stents have re-stenosis or maybe neo-atherosclerosis may be the reason why. And instead, or in comparison with patients assigned to CABG, there was no real difference between the rates of revascularization after the first year, despite the presence of angina. And here is the real important data. All-cause death up to 10 years of follow-up in the synthesis trial. You can see it's clear for all of us. Okay, there is no difference between any of the strategies for revascularization in patients with complex coronary artery disease. And finally, the ischemia stent. Remember, ischemia, a very important trial, patient with stable angina, complex coronary artery disease, not including left main coronary artery stenosis, and evidence of ischemia, moderate or severe at least. They were assigned in a random manner to conservative management or invasive management, whether surgical or percutaneous management. Here's the flow chart again. The first result were presented at 3.5 years. There was no real difference between the groups. And this is an extended follow-up phase. Almost 6 years after the initiation of the study, we got the results. And you can see rates of cardiovascular death were higher among those patients managed conservatively. You see that the intervention of the revascularization appears to improve in 22% the outcome of cardiovascular death. But remember that in ischemia and ischemia stent, death with unclear causes were considered cardiovascular death, where you can see this is a clear bias because we are not sure what was the cause of those patients. And a very striking finding of this trial that was seen even in the first report was that non-cardiovascular death was higher among those patients who were taken to the invasive strategy. I mean, invasive strategy in these patients increased the rates on non-cardiovascular death, and you can see 44% more than the patients that were more conservatively. And finally, if you make the same, or I mean, you have all the cardiovascular death and non-cardiovascular death, you get the all-cause mortality, and you see a neutral effect of any of the strategies. That means that our patients that are taken to the invasive or the conservative strategy won't obtain any benefit in terms of all-cause mortality, which is in line with the previous results from the Synthesis trial. So just three home messages. Please remember, Americans have changed the recommendation regarding exercise. Now we should engage our patients in resistance training. The Orbita 2 trial showed that PCI may be an upfront option for some patients with stable angina, but optimal medical therapy is the first-line option for all patients. And finally, recurrent angina after PCI or CABG does not increase long-term all-cause mortality risk, but certainly affects patients' quality of life. Thank you very much.
Thank you very much, Dr. Lopez. I mean, very good overview on what is new in chronic coronary syndromes. But let me ask you something regarding the Orbita 2. Now, I think it's when it was presented like the study that was the definitive answer for the efficacy of angioplasty. But how would you really regard the study? I mean, it's do you think that that is a practice changing, or it just shows that it's one alternative for treatment for some patients?
I think it's the last one option that you have mentioned. That's the reason why I wanted to go a little bit deeper into the details of the study, because I think that when you hear the abstract or when you hear the presentation of the EHA meeting, you have the sensation that this is real, the first one option for all patients, which is not. And why is that? Because first, 2 out of 3 patients won't have complete relief of the angina. I mean, the objective of the therapeutic intervention, in this case, an invasive intervention, is not get. Second, this is not out of risk. You know, patients taken to the cath lab have a risk of problems or technical problems during the procedure. And besides, after you got a stent into your coronary arteries, you got the risk of stent thrombosis and also the risk of coronary neoatherosclerosis. So it's not as simple as to choose between PCI or not PCI. I think we should tell our patients the alternatives, and maybe most of our patients will choose medication which are less risky and not that expensive, at least for our limited resource settings in Latin American countries. And then we should leave PCI for those patients who don't have a good response with medications. But some may argue that was already tested or proved in the Orbita 1 trial, which showed that if you take a patient to the interventional cath lab and revascularize a patient who has been previously on a lot of anti-anginal medication, you may not find a good relief. Well, maybe the reason for that is that because opening an artery is not the answer for that patient, and we should look carefully about other causes of pain. But in my practice, I think this is just an option, or for some patients, especially for young patients who do not want to take anti-anginal medication, but not for all patients.
And I think that the other point is that for many years we've been polarized, saying either angioplasty or medical therapy. What do you think of the fact that patients with taking medical therapy sooner or later will have an angioplasty, and those patients who take or receive an angioplasty, as you've shown by the also the Orbita 2, but also in the ischemia, they take all the medications. So I think that there's not a question of saying either or there should be something that should work together. What's your view on that?
I think, well, even American guidelines had pointed out that it's important to share information with patients and let our patients to participate in this and tell you exactly what you have already told. Patients need to know what is the natural history of the disease. Maybe they will find some relief for some months, even for some years, but at some point they will need to an angioplasty. I think, let me just tell this, as another anti-anginal medication. I mean, it's an invasive procedure, but it's just another anti-anginal medication, which seems not to be the holy grail that we expected to have in this trial.